I'm the founder and executive director of Rethink Breast Cancer, and we're all about creating spaces to connect, heal, listen, learn, and rethink breast cancer together. So we're so glad you're here to help us with that. Before we dive in, though, to tonight's session, we do want to take a moment just to ground ourselves and acknowledge that the land that Rethink's office is located on, where we're managing this Zoom from, and just talk about the land that we're gathered on this evening. So, on behalf of the Rethink team, we are grateful and honored to live and work on the traditional territory of several nations, including the Anishinaabeg, the Mississaugas of the Credit, the Chippewa, the Haudenosaunee, and the Wendat peoples, which continues to be home to many diverse First Nations, Inuit, and Métis people today. And we stand in solidarity and allyship with Indigenous peoples of these lands and beyond in their fight for self-determination and decolonization. So just a few quick housekeeping notes. As you know, tonight's session is being recorded, so we may be sharing portions of this video on our social media channels so that our wider community can benefit. And there will be time for questions at the end. So we're going to let our guest take us through a bunch of updates, but you can drop your questions in the Q&A, and then I will be pulling from those and helping kind of make sure we get as many questions answered as possible. And just that other little gentle reminder that tonight's conversation can offer general guidance, but when you're asking your questions, I'll try to do a little bit of converting if it's getting too personal, but it's really not meant for personal medical advice. We're just giving general updates on what's been happening. And in the room, we will, of course, have people with early breast cancer, metastatic breast cancer. There may even be some caregivers in there. So that's my housekeeping. But now on to introducing our fabulous guest. Tonight, we're joined by someone who's not only brilliant, but she's a true friend of Rethink, Dr. Christine Brezden-Masley, or as we fondly call her, Dr. B. She has been a longtime Rethink board member, and she's also just a super fierce advocate for women, for women's health, for women with breast cancer, especially young women facing breast cancer. So I think she brings a very cool and important combo of having a big brain with a really big heart. She is an MD, but she also has a PhD in medical biophysics, and she's also one of the most compassionate physicians I know. So she's got a big bio. She's the medical director of Marvelle Koffler Breast Centre at Mount Sinai Hospital in Toronto. I think she's also the medical director of their whole cancer program at Sinai Health. She's also a clinician scientist and associate professor at U of T. She does a million other things and somehow finds time to help charities. And we're just so grateful to have her. But she's here today as our Dr. B, and she's been our trusted guide. We've done a few of these sessions before. And today she's going to take us through a bunch of things, like everything that's kind of new and meaningful from all the conferences she's attended, all the patients she's seen all year, everything she's learned. And she's going to help distill that down for us. So Dr. B, thank you so much for being here. And just to dive in, like for those of us who haven't been immersed at all these important conferences, and I know you're also like a chair of the Canadian Breast Cancer Symposium, so you bring that important Canadian lens, but you're traveling to global meetings, you're on your way to the San Antonio Breast Cancer Symposium, so you probably are looking forward to some things there, but the floor is kind of yours to take us through that really high level general, like what should we be excited about? What should our community be excited about right now?
But first of all, hi everyone, and thanks MJ for that intro and for the invitation to spend the next hour with you. Honestly, I was just in the European Society of Medical Oncology, known as the ESMO meeting. It's an annual meeting, and it was held in Berlin in October, so just a few weeks ago, and it was packed with practice changing clinical trials that have read out for breast cancer. So I think breast cancer really led that meeting, and certainly it was really exciting to be part of it and to see how far we've gone and the improvements that we're seeing in survival. So let's start. It's been a wild ride this year for breast cancer, which is always exciting as a breast cancer treater and as part of your community. It's really exciting to see the progress that has been made and is being made with clinical research and discovery. So starting with early breast cancer, what we've seen, and in the breast cancer community, many of you have probably been on a CDK4/6 inhibitor for ER positive, so estrogen-driven positive breast cancer. That is a high risk of recurrence. What does that mean? So we know that 75% of breast cancers, of all breast cancers, are driven by estrogen. So if you've been diagnosed with breast cancer, most likely you have an ER positive, HER2 negative breast cancer. And in the early stage setting, we look at what does that breast cancer look like to us? How much ER positivity does it tell us? Is it a ductal versus lobular? Most commonly, 75% to 85% of patients will have a ductal cancer. Lobulars are a little bit different. We're learning a lot about lobular breast cancer. It is a different subtype of breast cancer. But it's pretty common. It's 15% of all breast cancers. The issue now is, as you know, we have genomic aids for ER positive early breast cancer, like Oncotype or MammaPrint, and it kind of tells us what's the risk of this breast cancer coming back. Does this breast cancer need chemotherapy to prevent it from coming back? That has been a game changer. We're not now just throwing, chemotherapy at every patient. Honestly, if a patient does need chemotherapy, we don't want to give them chemotherapy. We've learned that our high-risk patients, so who are these? These are patients who have, 4 or more lymph nodes that have been involved with ER positive, HER2 negative breast cancer. That's a higher risk of breast cancer recurrence. Why? Is because those breast cancer cells have left the breast and they have now moved to the first set of organs, which are in the axillary lymph nodes and the armpit lymph nodes. Those are the first set of organs that it's moved to. So that's kind of a gauge, a marker to us. Is this breast cancer high risk of recurrence? We know that even N1, so 1 to 3 lymph nodes, there's a subset of those breast cancers that are high risk of recurrence. We also know lymph node negative, bigger tumors are at a high risk of recurrence. So what has happened? We have pushed for younger women, premenopausal, to be treated with ovarian function suppression, right? So we shut down the ovaries because the ovaries are the powerhouse of estrogen production. And we've now given treatment with better anti-estrogen therapies, such as aromatase inhibitors, anastrozole or letrozole. So that's our premenopausal. But now we supercharge. We supercharge the estrogen signal with a CDK4/6 inhibitor. These are pills as well that actually stop the cycling. These are cell cycle inhibitors. They stop the cycling of breast cancer cells. And there is an intimate relationship between the estrogen receptor and cell cycle. And so abemaciclib, or known as Verzenio, or ribociclib, known as Kisqali, have both demonstrated benefit in reducing the risk of breast cancer recurrence. Not only in the breast, but we've learned that these recurrences are distant, so lung metastases, liver metastases. And now we've seen that there's about a 35 to 40% relative risk reduction when these drugs are added to these high-risk patients. So at ESMO, a few weeks ago, we saw 5-year data for Kisqali and also 7-year data for Verzenio. And the very first time we've seen an actual overall survival benefit with Verzenio. So these drugs are extremely important. Just to let you know, it's 2 years of Verzenio with your endocrine therapy, your anti-estrogen therapy, and it's 3 years of Kisqali with your anti-estrogen therapy. And even when this therapy is stopped and women are still on anti-estrogen therapy, there is still this carryover effect. So the survival curves continue to separate. So again, premenopausal women, this high risk, we should shut down the ovaries with an aromatase inhibitor. And our postmenopausal are treated with an aromatase inhibitor. So that was really exciting, that the first time ever we've seen an overall survival benefit on the Monarch E trial with Verzenio.
How do physicians decide which one of those is right for which patient that has high-risk breast cancer?
So great question. So the Natalie trial, which was the Kisqali trial, that actually had stage 2A, so lymph node negative patients with a high risk of recurrence, so high oncotype, for example. So these are all women who probably would need chemotherapy, okay? Whereas the Monarch E, which is the Verzenio trial, had only lymph node positive breast cancer patients that needed treatment. So it all depends on what type of pathology. So what is the type of breast cancer that someone's been diagnosed with, of which treatment they will receive. And there's an overlap. You can either have Verzenio or you can have Kisqali. Verzenio, 2 years, twice a day dosing and continuous dosing. More diarrhea with it, but we get really good at how to manage diarrhea. Kisqali is once a day dosing, 3 weeks on, 1 week off, for 3 years, and a little bit more white blood cell counts that can drop. A little bit of more liver toxicity, so your liver numbers might go up. You may not know. It's like we call it a paper toxicity. And a little bit more, so the white blood cells, liver toxicity, and we need to do ECG. So we need to look at your heart to see what the electricity of your heart is for the first two, because there might be some changes in how your heart beats, what the electrical pattern of your heart is. So those are really kind of the two main differences between the two. But the most important to me is that we have options. We have treatment options, right? So one is not working well for you, that we can switch you hopefully to another one.
Okay.
And that to me is important for our patients. So that's the exciting piece. The other big exciting piece for early breast cancer for young women is the positive study, which was pregnancy. So we have always been scared, oh my God, you can't stop your therapy if you're young and it's estrogen driven because that, your breast cancer is going to come back. Well, we now have data where we've seen that we can safely stop anti-estrogen therapy for up to 2 years. So these were women, young women under the age of 43 with stage 1 to 3 breast cancer who were on anti-estrogen therapy for at least 2 years. Okay. Then we stopped the anti-estrogen therapy and they tried to get a pregnancy. So either they naturally tried to get pregnant or they had reproductive support to get pregnant. And we've seen that 73% of these women had a live birth, at least one baby. So that was excellent news. And it was safely done. After those 2 years, after the pregnancy, some of them breastfed. Then they resumed. This is the most important thing. Over 70% of our patients resumed the anti-estrogen therapy, and their survival outcomes were great. So that interruption of 2 years of anti-estrogen therapy and to have a baby, because remember, when you're pregnant, your estrogen levels go a millionfold higher in your body. And we're always scared that, oh my God, is that going to activate some breast?
Trigger something. Yeah.
And it did not. So
Wow.
we compared it to controls, two trials called Soft and Text, and the survival and recurrence rates were a little bit less than these Soft and Text trials. So a truly controlled clinical trial.
It's so nice to have that longer term data. Like Rethink was excited. We helped fund the Canadian arm of that study. And I think, I don't have the exact number, but it was something like 300 and some Canadian babies were born.
Yeah, so this is so important to know this, right? That our young women who unfortunately we're seeing more and more young women diagnosed with breast cancer that they can still have children and safely. So this is something, please, remember if you're young and diagnosed with breast cancer, please talk to your treatment team because we do have safe data to do this.
Amazing.
So that was extremely important to see that longer term outcome. So that really was kind of our early stage breast cancer. I want to put a little plug in for exercise and lifestyle, and it's got a lot of buzz because of a colorectal study that was Canadian led by my friend and colleague Chris Booth from Kingston, where we saw when added to chemotherapy, there was a survival benefit that outperforms many of our drug therapies. So it's been a huge push for exercise. And I just want to put a plug in. Last year, an OptiTrain trial. It was for women during chemotherapy. It was as a Dutch study. Women during chemotherapy, they were randomized to go exercise. So just telling you to exercise, that's
Yeah.
the control arm. The second was resistance training HIT. So RT HIT, high intensity interval training. Okay. And the third arm was aerobic HIT, high intensity interval training. So someone asked a question, define exercise. Excellent question. Exercise needs to be modified to you. Okay. But the most important is for you to have at least, 150 minutes of I can't speak a full sentence um, during the week. So whether or not that's 5 times 30 minutes per day, that's kind of what you should be focusing on. But the OptiTrain was very interesting because, as I said, it was a whole slew of different women with breast cancer. So you could have HER2 positive, getting neoadjuvant chemo. You could be adjuvant chemo, ER positive. You could be a triple negative breast cancer patient. So a whole slew of different chemotherapies, different diagnoses, different ages. But what was so astonishing, and this was during chemo, so not after, right? The challenge study in colorectal was
Okay.
after chemotherapy. This was during chemotherapy, 16-week course. And what was very interesting was that the RT hit provided almost an 80% relative risk reduction in breast cancer recurrence. 80,
Amazing.
right?
Amazing. I have
The
a question
R,
though.
the
Did
RT
that
hit was the
include
winner.
metastatic? Did it include metastatic?
It was no during chemo.
Okay, because I just came back from ABC Global Alliance and they were sharing all the exercise benefits for the metastatic community as well. And our lovely MBC advisory board has been, I think, leaders. Like in 2022, we had a couple people push back. We were showing an exercise study and we noticed, oh, it's not open to metastatic because that's that old thinking about metastatic that it's about
Absolutely.
stage instead of what you're capable of.
I tell all patients, people will ask me, oh, what should I do? What can I do? Please stay away from, mushrooms and all the other stuff. Please stay away. It's very toxic to your liver. Invest your money in exercise. Invest your money in moving. Get yourself, if you need to invest in something and take power over anything, lifestyle choice. One of the most important is exercise. Whatever that looks like for you,
Mhm.
whatever that looks like, because it's not one size fits all. But if you can move during chemotherapy, metastatic or adjuvant, so curative or metastatic, move. And really, you can get apps. There's so many apps out there. You see them all menopause, doing whatever kind of yoga or whatever. Move. The most important thing is to move. You're going to feel a lot better.
Mm.
We've seen better outcomes with getting the treatment in, less arthralgias, better cognition, less depression, anxiety. Like it just goes on and on and on in terms of benefits. So I'm going to stop there because that is what I just wanted to plug in. Please move. And
Yes.
definitely the next thing we think needs to do, even better sexual function. Like the benefits are outweighed, but the most important thing is there's survival benefits with your breast cancer that can even outperform what we're doing in terms of targeted therapy. So I'm going to now move towards targeted therapy.
Okay.
So, with the ER positive, the most common, the ER positive metastatic, we've seen the CDK4/6 inhibitors, which I just talked about early. So, as you know, we start in the metastatic for clinical trials, show improvements, and say, oh, it works. Can we move into the early stage setting? And so we continue to see the benefits with first line, either abemaciclib or ribociclib. Okay. And that is in the metastatic setting, first line. Now we're looking at what is driving that tumor and what kind of mutations occur in that tumor. One of the most common is called an ESR1 mutation, which is the estrogen receptor gets mutated. And now we have these oral SERDs. So these are you probably, maybe some of you are on fulvestrant, which is a bum shot, right? What it does, it basically takes the estrogen receptor, gobbles it up, and it basically destroys it. So it's a selective estrogen receptor downregulator. Now we have pill forms, and these pill forms are better than fulvestrant. They've done head-to-head trials now. We're seeing that the activity is better. And so these oral SERDs now, more and more data is coming forward. We're waiting for approvals here in Canada. But we're seeing activity with one called imlunestrant and abemaciclib, the EMBER-3 trial, that these combinations are very, very effective.
Okay.
And what was actually noted was we repurposed an old drug, and this came from Harvard. It was a study, and it was called the Avera study. And what it showed was they added an oral SERD plus everolimus. I don't know if any of you heard of Afinitor. So everolimus combination versus fulvestrant, and there was benefits in progression-free survival. So repurposing an old, very effective drug with a new novel drug, we're seeing activity. So we're going to wait and see more and more. The data is reading out, and we are going to have these drugs available in Canada. And just a
Okay.
plug, as I said, in the metastatic setting, we move it into the early setting. We just got a news flash, and I'm hoping we'll see the data San Antonio,
Okay.
that in the adjuvant setting, this oral steroid known as giredestrant outperformed an aromatase inhibitor. Now the toxicities are less. So we say there's less, achy joints, less hot flashes. So really exciting, I think, that we're going to be seeing that data read out. And again, we're changing how we treat ER-positive, HER2-negative breast cancer. So the other thing is, you probably have all heard of ctDNA, you've heard of it, liquid biopsies. How do we use it? There is more and more data coming out in the curative setting. Look at, minimal or molecular residual disease with ctDNA. But there was a study called Serena-6 that looked at ctDNA. So patients had to have, good response. They were on treatment for at least 6 months and stable. And then we started doing liquid biopsies. And if it was positive, we took a look to see whether or not this ESR1 mutation, because it's a pressure of treatment that this mutation occurs. So it is an inducible mutation. Whether this molecular change occurred in the blood before we saw it on a CT scan. And when that happened, when we saw that molecular change and we switched therapy, we switched to an oral SERD, patients did much better. Sorry, or fulvestrant. Patients did much better. So the molecular ctDNA, before a CT scan change, we had better outcomes. Now, this is still, we kind of don't know what to do with it because we don't have necessary access to ctDNA. It's a big high cost every 3 months, and only a very small percentage, only 10% had a positive ctDNA. So I'm just saying that we're
Yeah.
still trying to figure this landscape out.
Yeah. I see
Stay
someone's asking
tuned.
a question about like that access question because,
Yes, but
could
stay
Canada get
tuned.
this soon? I don't think it's going to be soon, but
I think eventually, because we're now
eventually.
trying to find, there's different ways of looking at the oncogenomics in ctDNA.
Okay.
One is a droplet PCR. It's cheaper, faster, but it is only for select mutations versus oncogenomics and bespoke, which means I take a piece of your tumor and
Hmm.
then I see to try to match it with the ctDNA. So I've got really good sensitivity that I'm picking up the tumor. So we're still not there yet. I know there's a lot of excitement, a lot of buzz. Everybody wants ctDNA. We just don't know what to do with it yet. So I know, hold tight. We're getting there. It
Okay.
doesn't necessarily change treatment today because we don't have the drugs available today. It doesn't change treatment today. Um, and sometimes, we also think about anxiety, right? If patients are doing well and there's no symptoms,
Mhm.
sometimes we can coast much longer on that treatment without doing blood work, and increasing the anxiety of our patients and us,
Yeah.
right? We go through this journey with you, remember. Um, so I think the other big piece is looking at this PIK3CA, AKT pathway. You've heard of alpelisib. There's a new drug on the market, inavolisib, which is combination with palbociclib and fulvestrant for patients whose disease relapses early
Okay.
after, either being on anti-estrogen therapy in the early stage setting. About 40% of ER-positive, HER2-negative patients will have this type of mutation in the tumor. and so would be a candidate for either capivasertib. So we have these pill forms, and all I'm saying is that we try to push the treatment as long as we can. And
So
then,
that's a first line if you've had a recurrence quickly. You would
yeah,
try that first.
yeah. And another one is the inavolisib. So all that data is reading out, and we're waiting for approvals in Canada to get that drug to our patients. We currently have capivasertib available to our patients today. Um, then now we're blurring the lines of HER2.
Yes.
So HER2, as you know, 20 to 25% of our breast cancer patients will have amplification or a lot of their HER2, which I say there's a little antenna on the cancer cell. And that cancer cell, that breast cancer cell is screaming with these antennae. That's a HER2 positive amplified tumor. Aggressive nature of these tumors. And we know that trastuzumab, the very first monoclonal antibody targeting HER2, changed the whole biology of this breast cancer. Our breast cancers are surviving, and this has been one of the first. We talk curing the incurable, right?
And that's Herceptin,
Metastatic
right?
patients,
That's
yeah,
Herceptin. Yeah. Okay.
yeah. So Herceptin and Perjeta in the metastatic setting, the Cleopatra trial, curing the incurable, right? We have about 15 to 20% of our patients that will have stable disease, not NED. I know a big push. A lot of my metastatic patients say, I want NED, I want NED. Remember, NED is not common. It's less than 10%, because once you've had cancer that spread to your organs, you're still going to have scar. So when I scan you, you're going to have maybe scar in the liver or scar in the
Mm.
bones, sclerosis in the bones. So there's no evidence of disease. I would say there's no evidence of active disease. That's what I tell my
Okay.
patients, right? There's no evidence that this cancer is progressing. So we have stable disease. So stable is good. Shrinking is good. Okay.
Mhm.
Anyways, back to this. So we had trastuzumab, pertuzumab, and then we had the very first antibody drug conjugate known as trastuzumab emtansine or Kadcyla, which
Mm.
basically was trastuzumab with chemotherapy attached to it. That was the first generation. And we've seen this treatment in metastatic HER2 positive breast cancer, and we've seen it in the curative early breast cancer HER2 positive when patients got neoadjuvant or preoperative chemotherapy and there's residual disease. They would get 14 cycles of TDM1. Now we have a better HER2 targeted antibody drug conjugate known as trastuzumab deruxtecan or Enhertu. And Enhertu is an incredible drug because it provides a huge cytotoxic payload, 8 chemotherapies. I could never give anybody this chemotherapy. I'd kill them. Because it's just too toxic. But it packages into a smart bomb, and
Okay.
it packages it with this really neat cleavable linker technology. So it links these chemotherapy bombs onto your HER2 target. It goes to a HER2 overexpressing cancer cells, goes inside the cell and blasts it. In addition, this is the latest, in addition, it has a bystander effect because not your tumor, your breast cancer tumors are heterogeneous. So you'll have a lot of HER2, but maybe some HER2 negative or HER2 low, and it will kill off those neighboring cancer cells. So we've seen incredible response rates. We've seen survival. We've seen it in the third, fourth, fifth line setting in HER2 positive metastatic. Then we moved it into the second line setting, which is now standard of care, replaced TDM1, and now we moved it to the first line setting, and we've seen called Destiny Breast 09. We've seen again survival benefits. The issue now is we've moved it into the early stage setting, and that was presented a couple of weeks ago, Destiny Breast 11 in the neoadjuvant, and we saw improvements in pathological complete response. So again, no evidence of disease. We've seen pathological complete responses, and we know that when women receive preoperative chemotherapy and a PCR is achieved in with the tumor, so when the tumor comes out, it's dead. There's no cancer there in the lymph nodes or the breast, PCR, that your survival outcomes are very good. And so we've seen significant improvements, an additional 12 to 15%.
Wow.
In the ER negative, HER2 positive, we achieved 87% PCR. So
Wow.
incredible.
Wow.
Then another study, DB05. So I talked about TDM1 or Kadcyla and the curative, like if you've had neoadjuvant, but you said cancer when it came out, you didn't have a PCR, so non-PCR, called residual disease. In our high-risk population, they compared TDM1, so the standard of care, to now Enhertu, TDXD, and we saw a 50% relative risk reduction in a recurrence.
Wow.
So 14 cycles of TDXD versus 14 cycles of TDM1, we saw a benefit with TDXD. So as you can see, we're getting
So
better,
things are
better,
moving
better.
around.
Yeah,
Like,
but we're
yeah.
getting better and better in curing breast cancer. That's all I'm going to say. So I'm very excited to have the opportunity to start using this in early breast cancer, especially for our patients with a higher risk of recurrence, because we don't want this cancer to come back.
Mhm.
Okay. So that's the HER2 positive. And now we're seeing, kind of newer drugs coming forward. So it's really exciting. And in a couple of weeks at San Antonio, we're going to see data readout for HER2 CLIMB-05, which is the use of an oral drug called tucatinib. We got signal that this is a positive study in the patients who have, stable disease, to prevent brain metastases. We know, unfortunately, metastatic HER2 positive breast cancer, about 50% of our women will develop brain metastases. And so we're trying to find ways of improving outcomes, and HER2 improves outcomes. In fact, there was a study known as Destiny Breast 12 that women, very first time they had brain mets, they got in HER2 and they didn't need radiation. Like it
Mhm.
actually shrunk the brain metastases. So we're getting really, incredible results within HER2.
I
And
think what's also interesting, I just heard about this at ABC, or my perspective changed because I would always hear more brain mets for the HER2 positive metastatic, but it's because they're living a lot longer. So they have, unfortunately, like they're not giving. My mom died of liver mets within 7 months of her metastatic diagnosis back in like 1992. Today, people are living longer, but then they have the time to develop the brain mets.
yeah, that's one thing that that they have time to develop brain metastases, but also we should be looking for brain metastases because we've got really good targeted therapies. We've got stereotactic beam radiotherapy, we have gamma knife, where we can actually get rid of that one and not have it spread anywhere else, right?
Mhm. I see
So
that someone was asking a question about what treatments cross the brain-blood barrier. Does HER2 cross?
yes, it does.
Can you tell us a little bit more about like the importance of crossing the brain-blood barrier, but then also other treatments have benefit no matter what, and then there's all these other options for brain mets.
Yeah, so the other option, as I said, the HER2CLIMB-05 is going to be reading out at San Antonio, and that's with a pill called tucatinib.
Mhm.
And so what this study was women first line therapy. So, you got your pertuzumab, trastuzumab, and your chemo. And then you got randomized to tucatinib versus, nothing. Nothing being you could have still had anti-estrogen therapy. Okay, so you still could have been on an aromatase inhibitor. Um, and so these women, so you could have been tucatinib aromatase inhibitor versus just an aromatase inhibitor, for example. Anyways, it's a positive study. And we know that tucatinib has a effect in the brain as well. And so I'm going to be really interested to see that data. Does it prevent brain metastases, right? What is the survival benefit? We certainly know that a trial using palbociclib in this population provided a significant benefit in survival. So we're trying ways of, it's called the Patina trial. We're trying ways to actually improve survival in our patients with metastatic HER2 positive breast cancer. And stay tuned because there's more antibody drug conjugates coming. There's more combination therapies coming to make improvements to prevent brain metastases and to effectively treat brain metastases because they do cross the blood-brain barrier. Remember, when there's brain metastases, your blood-brain barrier is probably disrupted already. So it does get that opportunity to have these effective therapies cross into the brain. So that's the HER2 positive. I know there's so much going on,
Well,
and
I know I want
I'm
to get
probably
to
going to
triple
forget
negative.
something. So please ask questions.
No,
I'm going to end off.
I want to get to triple negative, but I
Yes.
mean, maybe we segue because for the HER2 positive MBC community, it's now not taboo to maybe even talk about it becoming a chronic for some people.
Yeah, I call it curing the incurable. It's a chronic disease. A lot of my patients who have such good long-term treatment effects, I call it the spa day. They come once a month now because
Mhm.
they're stable. Their disease is stable. I scan them twice a year. Their disease is stable. And now the question is, after 7, 8, 9 years, do we stop?
Mhm.
Do
Or the
we
treatment break,
stop? Do we
or
take
the,
that risk and
yeah.
stop? And we have conversations all the time. I'm like, we we've had some signal. It's almost like a 50-50. So maybe this is where ctDNA might become effective, right? The,
Interesting.
the
Yeah.
bespoke ctDNA. So this data will start coming out. But today we don't have, we're just gonna, it's a discussion with your patient, quality of life.
Hmm.
And if you want to take a treatment break, well, then we hold and we wait and see, and we then scan. We scan then a little bit, maybe every 3 months or 4 months, just to make sure that stability. But honestly, if this cancer doesn't come back in a few years, I doubt it's going to come back. I think his patients are probably cured of it, even in the stage 4 setting. So, I think this is something that's so exciting for me as a treating medical oncologist to see my patients do so well, because this is absolutely rewarding to all of us. Your win is our win, right? And so I think it really also drives clinical trials, research, survivorship. So there's survivorship is a whole other big realm that we have to really focus on and have that conversation at the start. We talk about survivorship right when I meet you. Treatment plan is laid out, and you have to survive this. You have to, the day you're diagnosed with breast cancer, you kind of become a survivor.
Yeah.
Okay, now triple negative breast cancer. This is the worst breast cancer that I unfortunately have to treat, in the sense that it's aggressive. When it is metastatic, it is so challenging to treat. Our women do develop brain metastases also with triple negative breast cancer. About 30 to 40% of our women will develop brain metastases. So there's another population that we should be scanning the brain. But there is positive data that came out. We had 2 trials that were read head to head at ESMO. One of them is Trodelvy, known as sacituzumab govitecan. As you know, we've had it in second, third line treatment for triple negative breast cancer. Well, now we've moved it to first line. This is a patient population, the metastatic setting, that unfortunately has a short survival. So we need to extend that survival. We need to do the best that we can for a triple negative metastatic population. And so we need to put our best treatments up front. So we have had immunotherapy. So this is the only breast cancer that we use immunotherapy for, both in the early and the metastatic. In the metastatic, we need to look at the signals called a CPS, or combined positive score, to see on the tumor that there's a signal for immunotherapy. And if that signal is 10 or more, the CPS score 10 or more, then we can use Keytruda, which is pembrolizumab immunotherapy. It's an immune checkpoint inhibitor, and that's added with chemotherapy. So again, it supercharges that chemotherapy in the triple negative breast cancer patient. 2 trials read out with sacituzumab govitecan, known as Trodelvy, in first line, showing it is better than chemotherapy. So in the immunotherapy patient population with that CPS greater than 10, it's about 30 to 40% of our triple negative breast cancer patients who have metastatic disease. Adding, so sacituzumab govitecan, the ADC antibody drug conjugate, the smart bomb,
Hmm.
with immunotherapy was better than chemo and immunotherapy. Okay, so that should be our new standard of care. And then sacituzumab govitecan in first line, again, better progression-free survival than chemotherapy. Another new drug, antibody drug conjugate, known as datopotamab deruxtecan, Dato-DXd. This is another one that shows effect in first line. So again, let's move our better therapies up front to show better progression-free survival so that this cancer doesn't progress, and also overall survival. So the Dato-DXd trial showed both overall survival benefit and progression-free survival, better than chemotherapy, both of these trials by 40%. So we really should be using these antibody drug conjugates up front.
Okay.
Then we look at the early stage setting, triple negative. As you know, we're using immunotherapy in all of our patients. And now we're seeing really pathological complete responses of about 65%. So it's incredible. So 35% will still have some residual disease. And now we're looking at using these, SG or Dato-DXd, so these antibody drug conjugates for patients with residual disease. And
All subtypes or triple negative?
triple negative.
Okay.
So this is the patients who get this Keynote 522 protocol, so the chemo plus immunotherapy, where we're seeing these improvements in pathological complete response. But the 35% of patients who do not achieve, whose tumors do not disappear, who have residual disease, we want to escalate therapy, right? Because we want to make sure this breast cancer does not come back. It has a high risk of coming back. And treating metastatic triple negative breast cancer is what I do not want to do, because the survival rates, unfortunately, are not great. And so that's why we need to do as much as we can to cure this population in the early stage setting. So those trials, those trials optimize SASE, these trials will read out.
Okay.
And we're going to be seeing improvements in early triple negative breast cancer, and of course the metastatic triple negative breast cancer patients. So stay tuned. There's more and more trials coming up, more antibody drug conjugates. It's getting really exciting because we're seeing improvements in survival, right? And there's small populations that can get a complete response.
Amazing.
So again, like if we can cure the incurable in this population, it would be
one. That is amazing. Thank you for all these big updates. We're going to run through some questions, but just like a high kind of level, one of the things that I think is challenging about giving these updates to our community at times is like someone might have just missed out on a new treatment. How do you handle that kind of question with your community where it's like, oh, I didn't get that. Like, can I go back and get it? Or is it just...
Yeah, no, great question. I mean, this is sometimes, patients do just where they are in their treatment landscape. If we can, high risk patients in the HER2 positive, if we can get TDXD, it's not yet approved in the Destiny Breast 05. So women who have had their, preoperative chemotherapy and they still have lymph node positivity and still a lot of residual disease. These are women that unfortunately do have a risk of recurrence. We know that Kadcyla decreases that risk by 50%, but the TDXD reduces that risk from Kadcyla an additional 50%.
Okay.
So, right now, whether or not we can do that. We saw data from the HERA trial a year ago at ESMO about tamoxifen, that tamoxifen was ineffective. So because of that, now in my HER2 positive breast cancer patients in the adjuvant setting, I am not using tamoxifen. I am using ovarian function suppression and aromatase inhibitors in my high-risk HER2 positive breast cancer patients. The subgroup analysis, we're going to see more data coming out from that.
Okay.
Lobular breast cancer. Someone asked about lobular breast cancer. What we know is that tamoxifen also is not effective in lobular breast cancer. So lobular breast cancer is extremely estrogen-driven. These tumors are bigger, more lymph node involvement, don't necessarily respond that well to chemotherapy, but we do know that an anthracycline taxane chemotherapy, based on our data, is still very effective for our high-risk lobulars. But again, this is where we're getting data with abemaciclib, known as Verzenio or Kisqali, where we should, in this high-risk population, use these adjuvant CDK4/6 inhibitors, ovarian function suppression if you're premenopausal, and an aromatase inhibitor such as letrozole or anastrozole. I would not use tamoxifen, and I tell my colleagues the lobular breast cancer patients should not be on tamoxifen. We want to maximize the anti-estrogen therapy. And there's some signal, there's a Canadian study that exemestane may not be as effective But I have to say, if you've tried all these drugs and only tamoxifen is something that you can tolerate, use tamoxifen. Tamoxifen is better than nothing, right? But if we just want to optimize all the therapy for our patients, and we're getting these signals and this data reading out, so we want to make sure that we do the best for our patients.
I like that point you made about all these having different options and trying different things because it's also like what your body can tolerate and the side effects and all of that. Okay, there's some questions here. So Jennifer's asking, can you share your thoughts on ovarian removal versus aromatase inhibitors like Zoladex in premenopausal patients?
Yeah, so it's a great question. I talk to my patients, if you're 45 and older and you've finished having kids or you're not going to have any kids, some women choose to have a bilateral sublingual oophorectomy. That's the big fancy word for I want my ovaries and fallopian tubes out. It's a 15-minute surgery. It's laparoscopic. It's outpatient. It's pretty fast on the majority. I just saw a patient last week that did have a bit of a post-operative complication. So on average, like it's still surgery, but some women prefer to have their ovaries taken out compared to doing a Zoladex shot. We now have data. Zoladex is a gonadotropin receptor uh, uh, antagonist, so the GnR antagonist. So basically shuts down the whole pathway of from the hypothalamus, sorry, all the way down. So you don't get any estrogen signal. So you put you into basically chemical menopause. We have data that basically it's a pellet that goes under the skin and it's given once every 28 days or once every 3 months. And we have data that once every 3 months is just as effective as once every 28 days. So we transition a lot of patients now to every 3 months. In fact, there's some data to say that that 3 month is probably better than
Going up and
the
down.
every 28 days.
Okay.
And our
Someone's also
prostate
asking
population.
about, yeah, someone's also asking about Lupron. I didn't see any mention about
Same
Lupron.
thing. So it's the same thing. These are both GnR arch antagonists. So these
Yeah,
are both
someone was
things.
asking like, why would an oncologist put an early stage ER positive IDC with no lymph nodes on Lupron if they're premenopausal?
So it all depends if you're high risk. So if you have an oncotype score that was like 32, and you're lymph node negative, these are women and it's a T2, say it's like a greater than 2 centimeter tumor, high grade. These are still women at high risk of recurrence. We saw data from Flatiron, real world data, that these women had the high risk of recurrence, just like lymph node positive breast cancer patients. So we're kind of getting smarter at who needs escalation of therapy based on our genomic aids, based on characteristics of the tumor. So we're getting a little smarter in terms of that. So we want the best for our patients. So we'll say you're going to need chemotherapy. And then after, if you're premenopausal, let's optimize your anti-estrogen therapy. This cancer is driven by estrogen. So let's optimize your anti-estrogen therapy. We shut the ovaries down. We give you the best anti-estrogen therapy, which is an aromatase inhibitor.
Okay.
And so that's what we do. And then
Okay.
with that population, you would get Kisqali as well. So we're layering, right? So the chemotherapy will give you a 35-40% relative risk reduction. Then the anti-estrogen therapy gives you an additional 35-40% reduction with the ovarian function suppression. And then the Kisqali supercharges that by an additional 35%. So our women are surviving, right? So that's why we do it.
Okay, because that same person was sort of adding more detail. I'm having so much difficulty with being on Lupron. And my oncologist said in a year after I'm done with Abema, we can stop the Lupron and go on to tamoxifen. So like just some confusion about all these different things that you're
Yeah,
trying.
so the question is, what kind of difficulty are you having? Can you
Yeah.
take a break? Can
Joint pain.
other ways of,
Yeah.
if the hot flashes are too much, there's a new drug, elizenetan. It was an Oasis 4 study that attacks the candy receptors, which, are leading to hot flashes. So
Mhm.
that's one. Sometimes vaginal dryness. I feel like I'm 100 years old, right? There's now intra rosa for sexual dysfunction. There's a lot of ways, and I know people are like, well, you're now telling me about another drug, and you
Yeah.
keep on layering on more drugs,
And you're also talking about exercise being like the best thing for us.
But I mean, this is the reality that, breast cancer is breast cancer. We don't want breast cancer to recur.
Mhm.
We want a life that is free of breast cancer. We don't
Mhm.
want metastatic disease. So sometimes I say it's, short-term pain for long-term gain. That's the chemo. That's the chemotherapy. But we do have to work with our patients to ensure they do have a good quality of life.
Yeah, absolutely.
But there are ways of improving that quality of life. Exercise is an important one.
Someone asked, is exemestane considered less effective than anastrozole and letrozole for ER positive IDC?
No,
No.
not
Okay.
that we know. Lobulars, there's a signal that it might be less effective.
Okay. Could you please discuss hormone positive PIK3CA MBC premenopausal de novo?
Okay. So what we do know is the PIK3C alpha mutation, so 40% of ER-positive breast cancers will have this alteration. What
Mhm.
does this mean? It's inside the cell and it's a driver. So it allows that cell to be, the cancer cell to be a little bit more aggressive in the sense that we've seen CDK4/6 inhibitors like the older one, Ibrance, palbociclib. Typically these women would be on average 2 years on a CDK4/6 inhibitor. If there's a PIK3CA alpha mutation, that was shorter. That was about 12 months, okay? Because it made a little bit more of a resistant mechanism to the anti-estrogen therapy. We saw that some women that are on anti-estrogen therapy say you're on tamoxifen, and then you go into early menopause, and then you switch to an aromatase inhibitor like an anastrozole. Excuse me. And then you're on treatment for 4 years, and then, oh my God, all of a sudden I'm feeling unwell and I've got bone metastases. So these are women that were part of this ANAVO study that we looked at ctDNA and we saw, oh, many of these women did have a PIK3CA alpha mutation in the tumor. And so that's where we target it with these small molecules such as inavolisib, which is a selective PIK3CA alpha, basically targets it, shuts it all down. Plus, it was palbociclib plus this other drug, fulvestrant, which is a SERD, selective estrogen receptor downregulator. All it does is this triple cocktail really improved overall survival in this really high risk, aggressive, ER positive subtype. I must say that abemaciclib, when we looked at all the trials, 3 trials now with abemaciclib and the molecular genomics, if the tumor had a PIK3CA alpha mutation, abemaciclib was still very effective. So I think this is something that we're now looking at. And the EMBER-3 trial that looked at abemaciclib plus inavolisib, which targets PIK3CA alpha, that this was a very, very good combination. So as I said, we're learning more and more. Some of these drugs work a little bit better than others.
Mhm.
And the most important thing is if it's a de novo PIK3CA alpha mutation still, if it was my patient, the first sign, if I could, I get abemaciclib with a aromatase inhibitor, because I
Mhm.
think that I can ride that first wave for a much longer than obviously than palbociclib.
Okay. I see a question here. I don't know if it's early or MBC, but how do you know if Verzenio is not working or working?
Um, well, in early breast cancer, we know when it doesn't work, if patients recur. Fortunately, I've not seen that yet
Mhm.
in my patients. And I've treated a lot of patients with high risk early breast cancer with Verzenio. In the metastatic setting, so if it's not working, if you're looking at your restaging scans, and typically they're done every 3 months, and you see that the cancer is progressing. So if you've got lung metastases or liver metastases or bone metastases, that you have multiple new bone metastases that are lytic, okay? One thing about bone metastases is that, they can be there and hiding. And once
Mhm.
you start treatment, then you see more sclerosis everybody. We're like, oh, you've got progression of your bone metastases. But really, it's probably those bone metastases were there, but now they're healing. That's more sclerosis. But
Okay.
if you do see a new liver metastases, or was 1.4 centimeters, now it's 2.4 centimeters,
Mm.
and multiple new ones, then you know your treatment is not working and you need to pivot to a new treatment.
Yeah. Okay, we are at 8 p.m., but there's just like a few more questions that'd be great if we could get to, if we could have like 5 more minutes. If you take a CDK4/6 inhibitor plus an AI and you still develop MBC, does that take Kisqali or Verzenio off the table as a line of treatment for MBC?
Yeah, so great question. It all depends on when. you develop metastatic disease. So what is the disease-free interval? So if you develop metastatic disease on Kisqali, then it all depends. We want to know what your biomarkers are, your molecular biomarkers of that tumor are. Is there a PIK3CA alpha mutation?
Yeah.
Is there ESR1 mutation, right? So we want to, is it AKT? What's that pathway? Is it mutated? Then we would pivot to something targeting that because that's
Mhm.
driving it.
Mhm.
Um, if it's 3 years later, then no, we would re-challenge with a CDK4/6 inhibitor. We have data, Monarch, um, you know, we've got data using Kisqali after palbociclib, Monarch, abemaciclib, Verzenio after Kisqali or after Ibrance, palbociclib, and we still see effect. But we just change the anti-estrogen. So you go from an aromatase inhibitor, say anastrozole or letrozole or exemestane, and then you switch it to fulvestrant. Or now we've got oral SERDs like imlunestrant, you know, um, camisestrant. So we've got different ones that are now showing better effect
Okay.
than fulvestrant.
Two more quick questions. Is there any data for young MBC hormone negative women who are NED for a while taking treatment breaks for pregnancy?
Um, Good question, and thanks for that question. It's something that you would have, yeah, NED for a while, triple negative. These are women that, you could consider. We at Mount Sinai where I practice, we have a huge MFM and fertility clinic. And there have
Hmm.
been a couple of metastatic patients that we've done, egg freezing and halted and
Hmm.
seeing what's happened. Most of our women will get surrogates
Okay.
and not necessarily carry a pregnancy. Now, that's a very delicate, sensitive discussion.
Hmm.
Um, you know, I can't answer yes or no. It really would depend where the cancer is, how well it's controlled. Make sure the brain is imaged to make sure there's no evidence of brain metastases. Theoretically, you could probably try a pregnancy. But as I said, a lot of our patients are a bit afraid. It's this uncharted territory. So breast cancer can come back with a vengeance, or you're perfectly safe. We just don't know. I mean,
That's
you
great.
might want to try ctDNA, to see if that's positive. There's ways of trying to look at this.
Hmm.
But we want you to have a successful pregnancy. We want you to, to carry a child or have a successful pregnancy with a surrogate. And I've had many of my patients have surrogate moms
Wow.
carry their babies.
Very cool. Okay, last question, which might be opening a can of worms, but I just kind of want to, this might be a topic for another day, but someone's asking if you can talk about integrative therapies such as the use of mistletoe injections, that this is commonly used in Europe, and is there any evidence of the efficacy of use?
So I am not a proponent for mistletoe or traditional Chinese medicine with mushrooms, for example, because it's very hepatotoxic, liver toxic. And the biggest concern is that these are drugs that can affect the liver, and
Mhm.
many of your drugs that you're on are metabolized through the liver. And so your liver now is competing and working harder, and your drugs may be less effective.
Mm.
So honestly, if you're going to do anything, I would not do mistletoe, not even high dose vitamin C. Vitamin D is worthwhile, 2,000 international units per day, calcium enriched diet. Definitely. A lot of my patients are on B complex. Some
Mhm.
of them are on omega 3, for cardiac protection and health. Um, but, St. John's wort, mistletoe, mushroom extracts, these are for me, they're a bit of a forbidden. I really try to uh, have my patients not take these extra supplements because I think they do more harm than benefit. And remember, this industry is not regulated.
Mhm.
Wherever
Mhm.
these drugs are compounded, it is not regulated. So who knows what you're taking? Who knows how it's made? The brand that I like is Sisu because I think that is one that's a well regulated for vitamins.
Okay.
But again, this is a conversation that's much bigger.
Yeah, it is.
Remember, it's we don't have really good clinical trials. We've got clinical trials for a few things.
Hmm.
Vitamin D,
Yep.
we've had clinical trials for acupuncture that's been beneficial. We just had a trial with it's called Polar that talked about decreasing peripheral neuropathy in the hands and the feet with cold compression. So I tell my patients you can buy it on Amazon. If you're
Okay.
getting a paclitaxel therapy or docetaxel, put it on your hands and your feet during the infusion. That has improved. We've got
Mm.
cold capping to
Yep.
decrease
Hair
hair
loss.
loss. I mean, there's so much, but the biggest is exercise. If
Yes.
you're going to spend money and empower yourself, exercise. I think the benefits of cognition, getting you through therapy, just looking good, feeling good. I mean, honestly, I can't say enough about tailoring an exercise regimen to you because exercise is a big term, right?
Yeah.
But
I
it's
think
a
the next thing
lifestyle
is that
change.
it has to be paid for as part of our health
I
system.
would love for it, and we are actually working on
Yeah.
that.
Yeah.
I think this is important
Yeah.
that we have some form of support for our patients, all cancer patients going through active therapy, metastatic or early, to really, this is probably something that empowers you. This is
Mhm.
something that you can do. And this is something that I would honestly spend money on.
Thank you so much. Okay, we're past time, but I just want to thank you for walking us through such a huge update. It's what I've been noticing the last Canadian Breast Cancer Symposium versus the one 2 years before. There's just so much now. Like there's just so many treatment options, so many types. I mean, there's the baby time positive study, there's exercise, then there's all these different treatments. So I don't know how you even do what you do and have all the conversations that are needed to be had with all your patients because we're heading into this more precision we're not heading, we are in more precision
We are in more precision
medicine.
medicine. I think it's
So
exciting times.
it's just a lot of information and thank you so much for helping unpack it and just, for showing up for our community and sharing your beautiful heart and your big brain. And, we'll be going through, we will share the video because there was a lot covered and I know it's hard to capture everything. We'll take some notes from that video and maybe do kind of a high level summary for everybody. And, just even pouring through the chat and your questions, that really helps inform Rethink about what the community is wanting to hear more about. So, follow us. I think you already follow us if you've joined this, but stay engaged in the conversations that are to come, and we've got lots of resources and community and support for you. So. I'll just say thank you to all of you for being here. Thank you to Trish for all your work on the back end on this event tonight. And thank you, Dr. B, for all that you do. Bye,
Thanks,
everyone.
everyone.
Thank
Bye.
you. Bye.